Welcome to the Humbert Experiential Learning Program, HELP, Revolutionizing Dysphagia Training and Education. HELP combines Dr. Ianessa Humbert's renowned expertise and immersive experiential learning, creating a dynamic educational experience for professionals involved in dysphagia management. Do you feel lost when conducting MBS and fee studies? Do you need help applying anatomy and physiology into your practice? Do you want to apply critical thinking to your swallowing evaluations? Do you want your swallowing practice to be patient-centered? Do you want to offer evidence-based dysphagia treatment? Well, the Humbert Experiential Learning Program is your lifeline. HELP offers all virtual learning that stimulates real-world clinical scenarios in dysphagia management, so that immersive learning is experienced through both pre-recorded and live-streamed sessions. Here's how it works. Deep dive into the fundamentals of our pre-recorded coursework on the Swallowing Training and Education portal, STEP, preparing you for real-world clinical scenarios. Then, join us for live-streamed sessions where you'll witness dysphagia diagnostic and treatment scenarios in real-time clinical settings with volunteer patients. Enroll in our upcoming HELP sessions now and take your expertise to new heights. Experience transformation with STEP and swallowing wellness.
Thank you so much for joining the Humbert Experiential Learning Program. And I should be looking here. So, hey, there you guys are. I'm so glad you guys joined us. So this is HELP. This is our very first one. We're very excited that you guys are joining, and we're excited that you actually watch the pre-recorded material because that's going to set you up to understand what happens today really well. So, my name is Ianessa Humbert, and I am the CEO of stepcommunity.com, also known as the Swallowing Training Education Portal, as well as the CEO of Swallowing Wellness Center. That is the world's first outpatient clinic focusing on people with swallowing disorders. We will have everything that a hospital has, including modified barium swallow studies and fees, except in the community. So think of us as the DaVita of swallowing. So what are we doing here today? Today, we are talking about post-stroke follow-ups. And importantly, we're going to show you everything that you need to see with regard to what a thorough post-stroke follow-up looks like. Now, we also hear you saying, in my facility, I wouldn't have access to everything. Well, we're showing you pie in the sky. What would it be like if somebody who's had a stroke, who needs a follow-up, has everything that he or she needs in order to have a thorough evaluation? So that's our goal today. We recognize that not everybody's in a setting where they can do everything we're doing, or that there may be things that you do differently than we did. And that's why you guys can interact with us through Zoom. I also want to make sure that everybody knows that we have two important people who will also be helping us move through the whole program. We have Rinki Verandani Desai and Leticia Mezem-Parker. They are going to be joining us through Zoom during our intermission periods to do some polls and some interactive things with you guys. Before I talk about the agenda, I want to talk about our sponsors. Our sponsors include Bracco, who provided the barium, Aspire, who provided the EMST device, Patcom Medical, who will be providing the fees, as well as Philips, who provided the C-arm. And we're very grateful to each and every one of them for being willing to help us along so that we can do everything, not only just in budget, but also with expert equipment and skill and products. All right, so what are we going to do today? Today, we are going to go through a few things. We're going to introduce Jim. Excited to talk to him. And during this introduction and interview, I will be asking him a lot about what he experienced, what's happened since we last saw him. And actually, the last time I saw him is the last video that you guys saw, I think in maybe 2018, where he was drinking on the barium. Where he's drinking the barium. He was always drinking the barium, right? And then we're going to move to do fees, and that we'll pull in Savannah Smith. She is a speech pathologist who works with Patcom Medical, and she'll actually scope and see what's going on in that area, and then we'll move on to modified barium swallow studies. So we are going to have a full packed 2 hours. We're excited to have you. And now we're going to talk to Jim. Hey, Jim.
Hey there.
Jim and I have been cracking up already for the last hour, so we're going to transition from being Canadian and Blue Jays and all the other things to talking about...
serious now.
We're going to be serious now, right? Okay. So, Jim, thank you for coming. This is Jim Pastorius, everybody. I know you guys already have interacted with him. I interviewed you for the documentary about a year and a half ago. Drove to Raleigh, hung out at his house, met his corgis. You guys can't see it, but his socks have corgis on them because his corgis came to Bethesda, Maryland with him from Raleigh. So
we go everywhere with me.
Jessica and Cooper go everywhere with you. Okay, Jim, why don't you introduce yourself?
My name, like you said, my name's Jim Pastorius. I had a stroke it was April 2nd, 2016, and one of the results of the stroke was the inability to swallow. So after being told I'd never swallow again, that's when a friend of mine out in New Mexico said, why don't you look at the studies? And most of the studies I found, they wanted the cancer patients. Very few studies, only 2 studies in all the United States dealt with stroke. And the one guy in Boston, he wanted like 24 hours after the stroke. Really, in 24 hours, I didn't even know where I was at. So that study was rolled out. It was probably after the stroke. It was about
2017. 16 or 17 is when I actually met you.
Yes. Yeah. So it was probably about a year after the stroke, that a year and a half, that I got involved in your study, and that was life changing.
Why was it life changing?
Up until that point, all the SLPs, they would show you the chart. The biggest thing is, and the attitude. Because if you know your kids, you tell the kids they're going to flunk something. I used to instruct race car drivers. They go, why would the race car driver hit the tree? The tree's out there all by itself. Well, because you're staring at it. So if the person's very negative, you're going to funk. You're going to fail.
Let me see if I just want to make sure I understood what you're saying. You said they show you the chart. SLPs show you the chart. You're talking about the posters?
Yes.
Oh,
I'm sorry, the poster.
I thought that's what you meant, because you mentioned that before.
The poster is two-dimensional, and sorry, I didn't understand it. And so you're very positive, and the technology was
there was technology.
Yes.
Nudge your hands.
Because all the other X-rays or the studies were done, you're really just a two-dimensional X-ray. They'd put the machine right up to so you're sitting straight up. And so, we tried different positions, and the technology down there in your study, is very, very positive.
So what I hear you saying, correct me if I'm wrong, is that you had, right after the stroke, right in that period when you have spontaneous recovery and your body really wants to improve, you didn't have an opportunity to eat and drink, and
correct.
Why?
They put me, they said I was NPO, and so you have to understand NPO follows you forever. Because I was just in the hospital, because I had a surgery done about 2 years ago, and so they didn't feed me. And they said, you were NPO. Well, that was a long time ago. So it sticks with you. And so I got off on a tangent. I'm sorry.
That's
the
okay.
question was...
You were going to tell me about the fact that you couldn't eat within the first 6 weeks after you swallowed, and you felt like if you had a chance to eat then, you might have recovered faster?
I really think that if the attitude was positive, and so so I did, I thought I swallowed. I was out of the hospital, so it was probably about a couple months after, probably about 5 months after my stroke. And so I was told, you could have swallowed. It didn't happen. And so that attitude, you didn't or couldn't, well, I must have been mistaken then.
So that's what you were making the connection with, as you were a race car driver, and you were saying that if drivers who are learning focus only on the negative, and you focus on the tree, don't hit that tree.
Yeah.
That's exactly what they're
Yes.
thinking about. Now they're going to hit the tree.
They're gonna
And
hit
you're
the-
saying at that time you needed somebody to have a positive attitude
Yes.
about something that was really impacting you.
And so, because we joked, when I first met you, the physical therapist, because they're very positive. You take one step, they're there. That's really good, and they have a whole bunch of different exercises. So every time you go visit them, they have something different, and they're very positive. SPs didn't have that.
Oh, I see what you're saying. Okay. So you felt like they weren't as optimistic.
Yeah, they weren't.
You're 100% right. I will not minimize your experience. The only thing I'm thinking that set them up to be less than positive is that your swallow was very severely disordered, right?
Yes.
Not a reason to not be positive, obviously. But in my circumstance, I knew I had all the technology that I needed, and I understood physiology enough to understand you hadn't had a pneumonia in a year, and you were otherwise healthy, and we knew that we could see what was going on. So I had a lot of reason to push you and continue to go forward. In an acute care situation, where you're going to be, or even in, you were inpatient rehab for a
Yes.
time, sometimes that technology is not there, and there's sort of liability all around you. So what I hear you saying is we need to figure out how to balance the healthcare constraints that we have with having positive attitude toward a patient. So even if they didn't have the technology, being positive toward you is something they could choose to do.
And so I was told when I was in the hospital after the stroke that it's a matter of luck. The swelling will return. We don't know why, but it can. Why should I believe anything you say after you tell me that it may return? Guess what? It never did.
So that's when you told me it will magically reappear.
Yes.
Okay. And that bothered you because it was sort of a empty promise that it could just come back.
It would just come back. They couldn't explain why it would come back. Why should I listen to anything that I'm told after that?
I hear you.
And if it does magically appear, maybe it's something they were doing. Maybe that should be in your little toolbox.
Right.
And, that'd be like they had to teach me how to walk after my stroke. And they never said it's magically going to reappear.
Right. Because that might make you think, well, then you don't need to work on anything because it's going to magically reappear. But at the same time, I'm hearing somebody say, if you thought you swallowed, you didn't. There's no way you swallowed. So you're like, what's the message here?
Yeah.
Got it. So let's talk about now. So thank you so much. One reason I love Jim, everybody, is that he's very willing to share his story. So he's very willing to say, this is what happened to me. This is where I am right now. And so we sort of really connected over his ability to be candid. But importantly, you went from when you first saw us not having anything by mouth to being no longer tube dependent. And it's not that we did that work. You did the work. We helped you. We guided you through it. But now you continue to be.
Well, I mean, you also put me up in Botox.
Yeah.
And so when I brought that up, a long time ago, because I was doing a little bit of research, and it was over in Japan or the Far East, that really the Botox, and they're so far advanced, and the Botox that they found really worked. And really couldn't find anybody in the United States. And when I brought up the SLPs, I was in the outpatient, I was kind of laughed at.
So there are a lot of people, ENTs, GIs even, mostly ENTs, who will do Botox. I think the issue is the healthcare system is difficult to navigate. So if there's a speech pathologist who hasn't seen your swallow and didn't maybe interpret it properly, instantaneously for us, like, you need Botox. There's no question about it. And then we had a person to refer you to right away who we had a relationship with. So it just worked out. But it could have been the case that they didn't identify that you needed it, and they didn't really know what the referral systems are, because sometimes you refer somebody and the doctor says, no, they don't, and then it becomes this back and forth. But the point is that it worked out for you, right?
Well, I mean, when I was at the outpatient, they really didn't know anything about Botox.
Oh, I see what you're saying.
So, I mean, that was totally empty. And so I have been getting the Botox injections.
When's the last time you had one? Do you recall?
About 9 months ago.
Okay, so where are you now with it? How do you feel?
It does wear off. It impacts people differently. It's kind of, because it can, like one time, I've heard like one time it can, you have one Botox injection, you can, swallow after that, or it's going to eventually wear off. And so I've been trying to push it like maybe 13, 14 months, so they'll do it annually. And it is covered by insurance.
That's awesome.
It is an
Makes a big
outpatient,
difference.
and pretty much you're up, you're about, and they'll put a diaphragm in, and you kind of flex the sphincter up to sphincter, and
So tell us about what your issues are with Botox now, because there are some negative.
there's like the impact, like mine will wear off, and so it is pro 13, 14. I'll try to push it to 14 months. The acid reflux, because as you relax the upper sphincter, that also controls what comes up.
Yeah, so you have more reflux now.
Yes.
And how has the reflux impacted you?
It can impact your teeth
Yeah.
because the acid's coming up, and so the only medication I'm on is a Prilosec. So I can tell, I was a little bit nervous about today's interview, so I did not take my Prilosec last night, so I can feel like a little bit of the acid reflux coming up. So I've had it before.
So you have some acid reflux. It's impacting your teeth, and your teeth are important because you of all people, you really need to chew your food properly. So you didn't take the Prilosec because you were nervous. Tell me more about.
No, I forgot last night.
Oh, you just
Yes.
So your anxiety about being on camera made you forget. Okay. I thought you were worried we'd still see the pill in there now. I was like, that's a good thing for us to go and check it out if it's in there.
Well, that's one thing that I want to make aware, the size of the pills. The Prilosec, it's a small little capsule, so it's pretty easy to swallow. So I'll do it nightly, usually with my bourbon and Coke.
Ooh.
But you get bigger than that, the pills can get stuck. Then they break down. And so as I was telling my primary, have you ever had, you have to ask yourself, have you ever had a pill break apart?
In your neck.
In your neck, because that can impact your swallowing for a day, for 24 hours.
Yep.
Because everything swells up.
And the other thing is, if people actually want to know more stories about this, if you go to swallowingwellness.com, the very first video we have there is of a person who doesn't have dysphagia, but had an issue with pill swallowing, and unfortunately the pills were disintegrating in his neck. He ended up with 3 holes in his neck, and then had an emergent visit to the hospital, and 3 months in the hospital repairing the holes in his neck because the pills just wouldn't go down. So certainly in his case, his upper esophageal sphincter won't let it pass. But in even people with just pill dysphagia, that can happen, and it's really problematic. And it's also nerve-wracking for people, right? Because you're worried about whether you're going to die.
Right.
Yeah.
And then you're worried about taking a pill again.
Yeah. So tell us a little about what you're eating now so we can make sure that this evaluation suits you.
I pretty much eat 3 meals a day.
Okay.
I do have to chew well. You're limited, and you kind of, for me, it's a little bit difficult to swallow. It's not a little bit. It's difficult to swallow, like fats, like pretty much bacon is out. Ribeyes are out. Why? Or unless I trim it up really well, because the ribeyes, the white stuff you see in the ribeyes is really fat.
Yes.
So that really doesn't swallow. And like lobster, I was telling because I wasted like $30 at a lobster food truck. Find out the lobster, it doesn't really allow you to chew it up that much.
Okay, so you couldn't really get it down. So you're saving money and cholesterol.
And the funny thing of it is, people ask, why do I cook a lot. I cook like every meal myself.
So you can control.
And when you're NPO, you don't have that ability. You're not cooking, so you miss it.
No, that's lovely to hear you say
And
that.
when you're NPO, you don't realize how much our life revolves around food, around swallowing. We take it for granted. Because people will ask, when you can't, because you take it for granted. Because you swallow like 1,000 times a day.
525,600 times. That's how many times you swallow a day.
Oh, really?
Every minute. Yeah. We should do a song and dance.
And so you take that away, Yeah, because I remember watching TV, the Coke commercials when they showed the little like ice
Yeah.
in the bubbles.
And the clink sound is so clinky.
Yes. And so it's like you're sitting there like, and it's really just an ad.
Yeah, but you want to drink that. I mean, we all see it and suddenly we want a Coke. I don't even want a Coke, but I want a Coke when I hear
Even
that,
like
the
peanut butter-
effervescence of it all.
Peanut butter and jelly sandwiches.
That's sticky. That must be, can you eat
Yes.
those? You can? So do you still take 45 minutes to get through a meal properly?
For dinner,
Okay.
I'll take 45 to, now it's down to 30 minutes.
Okay.
So that is, because you ask, because I see the ENT for the Botox, but the way I judge is my weight.
The what?
My weight.
Oh, your weight. Yes.
Because right now I'm like a little bit heavier, so like 34. I do have like 33 jeans at home. I won't give those up. So when I get down to those, I know. Don't forget. When I went before the stroke, I weighed like 225.
Right.
So when I saw you, I was down
You're
like
185, right?
probably less than that, like
Really?
170.
Oh, wow.
Because
Okay.
I went down to 155, and even the tube feeding, because I had I think I was doing like six protein shakes a day, through the tube.
And you were still small.
I couldn't put the weight on.
Okay. Well, we're going to actually transition pretty soon and get to the fees testing. But what I hear you saying is you are able to maintain your weight. There are certain things that are difficult for you to chew and swallow. Pills are sometimes a concern. And importantly, you want to do this check just to make sure that that you're progressing the way you think you're progressing. Because sometimes I know you have some sensory issues where you can't really always feel where things are. And so with some of your dentition changes, et cetera, this is probably a good time for us to check everything out thoroughly and give you sort of a point of reference so that if you do have changes, improvements or decrements, we would have some sort of baseline, a new baseline or milepost to go based on. Cool. All right, everybody, we're going to move to Rinky and Leticia, who are going to interact with you on Zoom for a bit while we change the set and get ready for fees. All right? And we're up. We're back. We right now have Jim, and he's complaining that it's his bad side because what you guys can see on the right is where his NG2 was for a long time. But it's not your bad side. You have no bad side. You're all good. And of course, we have Savannah Smith. She is a speech pathologist representing Pat Medical, and she's going to scope. We're going to start out with some non-swallow tasks, take a look, and we're going to move through and hopefully get through some, quite a lot of swallows, we hope. If you guys remember from the recorded videos, one of the biggest issues that he had is that the interswallow period, that refractory period, impacted his ability to swallow and clear. And so we don't want to have too much food such that he ends up with a lot of residue. So we're just gonna, it's gonna be touch and go like a probably typical clinical scenario. So take it away.
All right, you ready?
All right.
All right, so I'm just gonna take a look. You're gonna feel a little bit of a tickle here at first and then just some pressure, okay? Right. Pressure, pressure, pressure. Almost there.
How you
okay?
feeling?
Mm-hmm.
Okay. All right, welcome back. We got a friend on us. Here we go. In. Let's clear that scope real quick. There we go. All right. Beautiful. Can you say Donna? Donna?
Donna.
Good. Awesome. Very good.
All right, so what are we looking at here? Jim, can you see that?
Mm-hmm. Yep.
All right. What was the first thing you see?
A little bit of saliva around me. I can see the sphincter, the opening. You more and more some of the saliva.
Yep. Go ahead and clear that.
Do you want to spit? Do you want a spit cup?
Oh,
No?
oh,
Okay.
we're good.
Can you say E?
E.
Good. Can you do E?
E.
Good. E.
E.
Can you clear your throat?
E.
Good. You can try to swallow that. Okay, go ahead and try to swallow.
No pressure.
No pressure. Yeah, take your time. You're good. 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 Can you try to puff out your cheeks? I'm going to get a little bit closer. Go. Good. Kind of take a look here. Let's go a little bit closer here. Right. Good. Awesome. Can you try to hold your breath? If I can get down there. And relax. Good. All right. And swallow. We got friend on us again. And clear that off. Nice and mucusy down there. All right. I'm going to need to try to take a bite of ice. Try to clear that scope a little bit. And you can put your chin down if you want. You can relax. There you go. Lots of secretions. There we go. There we go. Beautiful. That really helped. Good. Nice. It's good clearance there. Go ahead and take another bite of ice. That was really helpful, I think.
Just a little bit more. Okay.
Nice. Good job, Jim. Then let's just see how you feel here. Some residue. Swallow whenever you feel like you need to. Good. And if you need to clear, we can...
How do you feel?
How do you feel right now?
Fun.
Okay.
Good.
Take your time.
Yeah. You're doing great.
Less mucus there than before.
Yeah.
I was saying the same thing, and not only do you have less mucus, what is there, it's very thin. Before there was...
The opening
Yeah.
a lot bigger.
So what are you talking about?
Yeah.
So that's actually your airway that's going into your trachea. That's not, were you thinking that that is the upper esophageal sphincter that goes to your
Yeah.
esophagus? Yeah, that's actually your,
your airway.
that's your larynx.
The that is a lot bigger.
But it's actually the same size. I don't think that the size of your larynx has changed. But what you're saying, I think, is you can see more because there are less secretions there. So it does appear bigger, but it's not actually bigger in
Okay.
size. Yeah, but you're right. You can see more. All right. So
And you're spending a lot more time than normal.
then the
normal
other
fees.
fees that you
Yeah.
had before was very quick. You told us that right after your stroke, you saw an ENT. He did one swallow and said you'll never swallow
Yes.
again. Yeah, that was discouraging.
Yeah.
And so you develop an understanding
Yeah, but
a little
this...
bit.
Yep. Go ahead,
All right,
do some
can we
water.
move on to some sips of water via straw? Okay, so I'm just going to hold this so that you can sip, and you sip as much as you would like.
Nice.
Really good. Do you
Really
want
good.
another test?
All right.
Okay.
Nice.
Great. All right.
So we're doing awesome.
What should we move on to?
Let's go ahead and do, let's do a puree. Let's do
Okay.
applesauce.
It's unsweetened.
Kyle? And take your time. Take your time. You're doing awesome. And is this position comfortable for you? You look tense.
Yeah.
I'm gonna try to
Yeah,
relax. There you go.
Relax.
Very tense.
Yeah. Just relax.
So typically, does it take you this many swallows? Okay. So just relax. So one thing that you don't want to do is you don't want to. Are you comfortable to not swallow in between, or do you feel like you have the urge to swallow right now? Like, do you feel
A
like
little
you're
bit of both.
okay? So you're probably thinking about your throat quite a bit. You're staring at it. People are thinking about it.
Yeah.
So it sometimes can keep your swallow from happening, right? And we already knew that years ago. Your problem is if you want to get a swallow started, and there's a lot happening, it's going to take you some time. So relaxing and making it more spontaneous could be helpful.
Yeah. And if you'd like a drink of water or some ice to help clear that out, you let me know what would feel good right now. If you were at home, this is how you felt, would you take a drink of something? Would you take a bite of something different? You were telling me earlier that you just stick with one thing at a time.
Yeah, one thing at a time.
Yeah.
You really don't want to talk in between,
Yeah. Yeah.
because that's what the clearing will happen.
Yeah. I will say, his sensation of the penetration is really good.
Huge. Yeah, this is really an
amazing.
improvement.
Yeah.
Would you like to spit?
Oh, I'm good.
Okay. Good. Are you up for a different texture? Or how do you feel right now? Because we're getting a lot of really great information, so we want to go with how you're feeling. And if you're up for something different, or if you want to see like a cookie or some
Let's try a cookie.
You want to try a cookie?
So you can see that.
Yeah, absolutely. We got them right here. We got our soft cookie and the Lorna Doone.
You chose the Lorna Doone.
It's good sensation.
How did that clear go? Before we give you anything more, I want to make sure that you're not in a place where you feel like you're taking a cookie because we're asking.
No,
Right,
'cause
exactly.
I can feel like some of the applesauce is still in the back throat.
Yep.
It is?
It is.
So do
you
you
wanna
want to
try it?
do you want to spit?
Yeah. Do you want to get rid of anything?
I don't think so. I don't think clearing will clear that. I think
We'll just take some time here.
Yeah.
I think the tense. I'm really very tense.
Yeah.
So it's not allowing the swallow to happen.
Sure. Would it be helpful if you stopped watching? Are you trying to watch?
No, because when you have something stuck up your nose and down your throat, no, it's there.
How comfortable can you be, right?
Yes.
Yeah.
And you know it's a test, and everything swings on it.
Ah, so you're saying in the
Yes.
past you've had these tests and you were nervous that you would
Yes.
fail them, and so that anxiety, I understand it. You can't fail.
And you can't.
Yeah, you
and
can't
you
fail.
can't swallow that way.
Yeah, that's true.
I don't care if you have a good swallow. If you're very tense,
Well, you're telling us what the literature says, actually, which is a lot of times we throw out the first swallow because it doesn't represent what their spontaneous swallow would be. Even in healthy volunteers that I've tested, the first swallow looks a little different because they're nervous, right? So,
and you got something stuck up your nose and down your throat, and you can feel that.
yeah. Okay. Well, we will do whatever you want to do next. We have a lot of information. The first thing we wanted to see was just structurally, what does it look like? What are you thinking about reflux? I mean, I'm not seeing as
I'm
much
not seeing-
irritation as
yeah.
I expected.
Not a lot of cobblestoning. A
Well,
little bit red in there.
every night, I do take the Prilosec.
Yeah.
So that's-
it's doing its job.
Yeah. So for what we see right here, you're not very red and irritated. It's nice and pink. And what it suggests to us is that the Prilosec might be keeping the reflux from irritating your larynx.
It's, that can wake you up the whole night.
Right. I've
You
had
can
it.
forget.
Yeah, I've had that. Okay, so the other thing that we were able to appreciate is that your secretions aren't as thick and abundant as they were before, and your voice obviously sounds much better actually than it did a few years back. And you haven't had this procedure since you had it in my lab, right? The camera.
One other.
Dr.
No.
Chetta probably did it for Botox.
Dr. Chetta may have, and no. I would say I did have the X-ray
Right.
done, the modified barium study done for up in Raleigh for Dr. Chetta.
Okay. All right. So you still have quite a bit of secretions, but a lot of that pudding that was pretty abundant doesn't look like it's quite where it used to be. It's not flooding as much.
Bumped up here. I floating. Come back in. There we go. Good. Yeah. And your sensation is really good.
Very
so you
good.
naturally are sensing the penetration and you're protecting your airway.
Tell people to breathe.
Yeah, just breathe. Just breathe. Yeah, that's really good. And look out.
How do you feel now?
Still tense.
A little tense.
I can feel it in the neck, or like right back through here.
Yeah.
You're doing awesome. You're doing awesome. This is very good.
Do you feel like there's a lot of applesauce still down there?
No.
Like, yeah, it's not.
Yeah.
Your sensation is accurate. If you don't feel it, we also don't see it, for what it's worth. So I guess the question for you is, would you like to test something more, or would you like to
try solids?
You sure? Because we can stop anytime you're ready.
And you're also gonna do a solid on the modified.
Okay.
So we don't want to push you too hard.
Okay.
Okay. All right. So I'll go ahead and come out. Okay. 3.
Good job.
Awesome.
All right. So let's have a little bit of a discussion about that. How are you feeling? More relaxed?
Yes.
Yeah, immediately as soon as it came out. Yeah, and so tell me a little bit more about the sensation. I know that you felt tense just because of your history with having tests before and feeling like you're going to fail. But did you feel like you had your neck back in a weird position? Is that part of it, or
Yes.
just
Or, yeah.
You looked tense.
Yeah, I could tell because, like I said, back here really hurt from tension, and so I think that impacts the swallowing.
It does. It does. Neck position definitely impacts swallowing, and so does tension. So and pressure. I hope we didn't pressure you too much. Did you feel pressured?
No.
Okay. The good news is that we got the information that we needed for this. Some things that we cannot get with this x-ray, we absolutely got with fees. So yeah, I'm glad you're able to go back to this. So go ahead, Savannah.
So initially, right when we're getting in there, we had talked beforehand that we were expecting to see those secretions down there. And as we play this, when you're clearing your throat while you're talking before even speech tasks, you're sensing this spillage posteriorly into the vocal folds here, and you're clearing it really well. So you're protecting at baseline very well, which is exactly what we want to see. So like Yanessa was saying, these are a lot smoother than they were. They're less gunky, which is going to help you when you're doing those pH, when you're eating. You're not so full that when you try to eat something that it's going to sit on top of those secretions and make it really hard to swallow everything. Because not only are you trying to swallow whatever you're choosing to eat, you're also going to have to try to initiate the swallow of those secretions, and those can be really hard to swallow sometimes.
You think they would have some medicine that would break up the secretions a little bit?
Right. So we actually did sometimes ice can help break up your secretions, and that's what we did first. So you can see here, after that first bite of ice, it really was clear. So that's something that maybe that you can, even if you feel like you have a lot of secretions day to day, maybe just chewing on some ice. Did you feel, I know you were really tense, it was probably hard to, feel.
The ice and water, they felt good.
Yeah, the ice and water went really well.
That is nice to know about the ice, because I'd never heard that before.
And that's what I was kind of wondering too, maybe even after the applesauce, if you say you only do one thing at a time, but maybe if you're eating something that feels a little bit more difficult to clear, maybe taking like an alternative bite of ice.
Well, if it is like, if you're eating dinner, how you may drink while you're, right when you're swallowing. So I'll wait until I swallow. But then, not so much washing it down, but maybe it is breaking up the secretions. I don't know.
Sure. Sure. Yep. So ice and water, went very well. I can fast forward a little bit to get to the applesauce. Something that I was noticing, and you made a great point of, do you normally take this many swallows or take this long per bite? And you said no, correct? It doesn't usually.
Correct.
Okay. You had a lot of multiple repeat swallows, and that can be really tiring. So once we took this bite of applesauce here,
all that sitting around. So what I'm glad you stopped there, because what we're seeing here is sort of the outline of your protection, which is your larynx. Like, so you have these walls that come together, right? So if my fists are the arytenoids, right, which you don't know what those are, but those are those two bulbs there. And then from my arm going up to my epiglottis, if my head is the epiglottis, you have this mechanism that kind of goes like this to protect, right? So nothing comes in this hole. And everything around is that green stuff, right? Those are the natural pockets you have in your throat to hold on to that stuff while we wait for the swallow to happen. So they are also supposed to disappear, dump into the upper esophageal sphincter, which is right back here, closed as it should be right now, because you haven't initiated a swallow. When you initiate the swallow, this opens up while this area closes. So they go from this to this. They sort of like alternate to who's big and who's small. Right now the airway is big because you're breathing, and the UES is small. But when you feel like something's kind of in between swallows slipping in and you need to clear, that's because in between the swallows, stuff is dumping into this space. And you're doing, the thing is that I'm telling you that's great, is before you didn't notice that that was even going the wrong way. And now you're doing all these movements to protect yourself, which is good.
Well,
there was
like you guys are taking the time to explain this. It's really the first time it's ever been explained to me.
Yeah. It's really helpful to also see it visually in real time. Because like she was saying, back here, there's the protective flap that's folding over your airway, and it's basically acting like a chute down your esophagus. So we'll go here a little bit, just so that you can see.
So you see how that's draining in, you made that movement? That was you protecting yourself. You tried to swallow, or you throat clear, or you cough. Because we don't want anything to go in. Now you're talking, and as you talk, it sort of dumps in there. You see that? All that green liquid is threatening your vocal folds, and that's the top of your trachea, and then after your trachea is your lungs. So you're doing all the right things by making those movements.
So that could explain, like, if I'm sitting at a bar having a beer, and you're talking to people, and that's...
And you're noticing that in between?
It takes more clearing.
Yes.
Because because that's when I have the spit cup. It's real thin. It's on a heavy mucus.
Sure.
So you're saying at the bar you have your spit cup in between. So you take a sip, then you're talking, and you notice it feels not safe, like something's going to go the wrong way, and you're able to just spit that out. That's smart. You're doing everything you should be doing.
That is something that you should go in the toolbox. Because I'll say the toolbox, because because they probably haven't spit before, and so I have that experience since I used to chew.
And teaching someone how to do it, and it's a little bit uncomfortable.
Yeah, and in this culture, spitting is considered to be rude, right? And so training somebody to spit, or telling them you're going to have to start spitting in public at a table where people are eating, you're breaking a lot of barriers. But what I hear you saying is, someone might say, I don't care about culture, I want to eat. And at least teaching them how to do that is a tool. Right?
So if you're showing this to them, what they're doing it for, protecting themselves.
It could also be really helpful if somebody is a talker while they're eating, and if they could see it, they're like, oh, this is why I should focus on one thing at a time. Just chew my food, swallow, then continue the conversation. We can kind of keep taking a look here. But your strength is really good. When you clear your throat, it's very powerful. You actually shoot it up, and I can see it coming up.
That's something that should be taught.
Well, we gave you the EMST device. Remember that device you were blow through? We brought one here because we know for you, coughing, expectorating, anything where you're driving up force.
I hate that device.
I know. Why do you hate it?
It's just... Because there's numbers on it.
There's numbers on it?
So
phones
it's
not
like
your
this.
thing?
No. Anytime in judging.
Oh, you feel judged.
Yes.
Oh,
okay.
You're competitive.
May I suggest
and
that
even this, because you can flunk, because you're told so many times, You failed this test.
Yeah.
So why are you nervous, Joe?
Yeah.
Yeah.
Don't, if you're told
Yeah.
a dozen times you flunked it,
Yeah.
you're scared.
Yeah.
Well, rest assured that we were very, very happy with.
No, 100%. But may I just suggest anything that has a number is not to judge you, it's to give you a reference point of improvement, which you have.
Well,
Meaning, if someone just says, blow hard against this tube, and you're like, but did I do better or worse than the last time?
Right.
You don't know. But if you see that there is, I'm now at a 30, or I'm out of this, or I'm out of whatever, you're like, I'm getting better. So it's actually meant to help you see your improvement than to suggest your failure.
and I think that's what the fees is too.
Okay.
Because this is, because you're showing me.
Yeah.
And so if the secretions, because, instead of just going, nope, you didn't pass, or,
Sure.
what was it supposed to be?
Yeah.
I don't,
Yeah. I'll show you this in slow motion here. So this is a really great visual of how you're sensing. So that's starting to spill over. Do you see how that's starting to spill over? And you get to a threshold where you're sensing it enough that
You
you are,
swallowed.
yeah.
That's
you
why it went
cleared
away.
your throat and then you swallowed. That white out is you initiating a swallow.
So go back just a little
Yeah,
bit.
of course.
Do I just do this?
Yep, just drag it back.
So, all right, I now hit play.
Yeah, yep.
I'm on your device.
No,
Like,
you
I don't know
got
what I'm
it.
doing, but I'm
Yes.
messing it up. So what you're going to see is your epiglottis is right there. It's going to come
go
over.
slow.
Yeah, how do you go slow?
Slow, we'll just hold that down.
All right, cool.
slow motion.
Fancy, Patcom. So what's going to happen is this epiglottis, see how it went forward? That's part of the protective mechanism that you're doing instinctively.
And when you're pumping your tongue back to initiate the swallow, that's driving that epiglottis. So even if you're not getting a full swallow, you're pumping your tongue back to kind of get ready to do the swallow, and it's pushing that epiglottis back.
I would suggest that one thing you can do volitionally that you might not be able to do the swallow volitionally when you're ready. The other thing you can do is throat clears. So when something's going down the wrong way, you're doing a movement, and I'm not sure what it is. It's sort of like, right? That's one way, but what that does is it brings it up. But throat clear targets just in the vocal folds and just sort of gives you a little air, or even that, even that.
Yeah.
It's like a little bit difficult with the scope.
Yeah.
Yes.
Yes. Yeah.
Okay.
The clear.
That's true.
Do,
Sure.
is the throat clear? Because I won't do that.
Sure.
Cool.
Was there something else that you were?
No, I think
interrupted you.
what questions do you have before we move on?
Well, this is very helpful because I really thought the fees was kind of a waste.
At first you did,
yes.
when they didn't use the tool properly.
And so taking the time to
I was
explain.
gonna say, why do you think that it was a waste? What was your experience or lack of experience with that made it feel like a waste?
They took about 5 or 6 minutes and really just, put the scope down, so you can't swallow.
Was this at the ENT's office that you're talking about, or is this a different time?
Both.
Okay.
And so we're in the hospital, outpatient, at the ENT.
Okay.
So every tool, when used properly and explained properly, does its best, right? So we're not going to use a hammer to get a screw out of the wall, right? Well, we could do that. That's not a good example.
Well, you can go small.
We're not going to use a saw to hammer a nail
You
in.
could essentially maybe.
I usually get at analogies. I don't know what happened. My batting average is not great. Oops, sports. Okay, so the point is that the tool works when it's explained properly, right? And this is an example of it being explained properly. Also, Savannah's an expert.
Well,
She
that's
does
what
this all the
everybody
time.
should achieve. Because this was helpful like a number of years ago.
Yeah. Yeah.
Yeah. Well, we're glad it's helpful now.
Yep.
Cool.
Awesome.
All right, we're going to transition to our next thing, and we're going to get ready for a little bit of X-ray and see what's going on with your upper esophageal sphincter, which I know is an important aspect to understand.
Okay.
Okay, let's do that.
Awesome.
That was amazing. Well, I just want to start by saying I knew what to expect because we planned this whole thing. But I think just watching as a viewer and actually seeing a patient's experience is just so empowering and so enlightening. And I just think everyone, this is just how we need to learn. And like a light bulb went in my head saying, why was I learning from textbooks? And why was I learning from other clinicians watching like these death by PowerPoint boring videos when this is what makes us better clinicians? Because unless we've seen what a patient goes through, what their experience is like, what their challenges are like, and what we tell them, how that's translating into meaningful information for them. What's even the point of all of this?
Yeah, no, I that was so awesome. What Jim said was so telling. He said, well, you guys are explaining it so well. And that for me was like, whoa, because oftentimes we just want to do the evaluation. We want to get down to the recommendations and we want to get down to the findings and let the physician know this is what we think. But I think there's so much missed opportunity when we don't stop or really slow down to say, hey, how are you feeling? What are you feeling? Can you tell me what's going on? Are you comfortable? Even something as simple as saying, are you comfortable? Is there anything that I can do to help you be less tense? And we know, I mean, FEES is not, especially FEES, it's not the most comfortable experience for a patient, right? So, and on top of that, they're nervous. There are all of these things, these factors we have to consider. But just stopping to ask, what is experience like for you in the real time at this moment? What can I do to help with whatever it is that you're feeling? And then providing that feedback, using that FEES monitor as a feedback and allowing them to see, look, like Savannah said, you're talking and eating, and this is what's happening. Things are going down the wrong pipe. So having that visual reinforcement, I think we need to use that to our advantage more frequently and do more educating and not be afraid to stop and say, this is what I'm seeing, this is why it's happening, and really just educate along the way, not have to wait till the end and do this grand thing, but really educating along the way as we see things pop up is, I think, very understated.
Oh my God, yeah. All of that was exactly what was going on in my mind as well. And we've been doing this a long time, right? Like I'm 15 years in and I still feel like I learned so much from watching this interaction. The two things that stood out for me were, one, the EMST. And I thought about the number of times I'll say thrown, but obviously I don't throw anything at my patients, but we're running around. We don't have time. We do throw handouts at them and we just tell them what to do with exercises. Very often they're paper exercises that have been printed out a long time ago and we hit print and we're giving it to them. So I would even think they're not really personalized for the patient we're seeing. If they're lucky, they'll get a handout. Oftentimes we're modeling what they need to do and they need to remember that and go home and practice until they see us the following week, if it's an outpatient setting. But I would have never thought something like an EMST, which I would have probably just handed over to my patient, would have led to the experience of, I don't like these numbers. It makes me feel like I'm failing.
Mm-hmm.
That was really a powerful statement and moment for me, because I think I just thought back and I was like, how many times did I stop to even ask my patient what they feel about my recommendations? We just hand them over to them. And the other thing, yeah, what you said, what he felt like he was almost so grateful that someone took the time to explain his study to him, which is ridiculous. That's not how patient care should be. If one of us were a patient in any capacity, I'm sure everybody has been a patient at some point in some capacity. For me, most recently, I was pregnant, so all my ultrasounds, I can't imagine walking into the clinic and my OBGYN not explaining what she saw with my baby. Exactly. But somehow in the swallowing world, that's okay. It's really not. And yeah, the final thing that I thought about was what you said about how uncomfortable these exams are. And very often patients walked in, they've never had something stuck down their nose. But if we don't prepare them, we don't tell them why we're doing it, we don't tell them what we see, because we're not trained enough to even know what we're seeing other than looking for aspiration or residue, it's such a grave disservice to them.
Yeah, no, I completely agree. Patient education and oral care are the two hills that I'm always willing to die on. Like, those for me are just like big things. So it was neat to see it all come together. I think Jim definitely is going to walk away from this entire experience with so much more understanding about what's happening in his body with his swallow at the moment. And I think it'll be a nice point of reference when he thinks about where he's coming from, right? Years ago when the stroke first happened and when he first started working with Dr. Humbert. So this is really good for him too. And I'm excited about that. Just all the information he'll have will be really cool.
That made me think of another thing where we also almost think, or at least I did as a clinician, almost thought about treatment as like the static thing, because it's often driven by reimbursement. How many sessions can you get? Productivity, how much time can I see? How many minutes can I see my patient? Which I get, there's a business side to things, but it really takes away from patient care. And I think for so many years as a clinician, I always just thought about these are the impairments. Let me write my goals. In a month, I'll do a check-in again. But I feel like as we're having experiences like this and we get our clinical skills and experience and more experience under our belt, what we should stop to realize is that treatment is this ongoing dynamic process. And it really needs to change with the patient's goals, that we need to check in each session they're with us, not each month. The patient's support system, social determinants of health. I've worked in Dallas in acute care, in New York in inpatient rehab, and in Mississippi now in outpatient. I can't even tell you how different the experiences were with just being an SLP in these different states from a socioeconomic standpoint, and the kind of patients we see, how different each of these settings are in and how they set the patient up for success. Like right now in Mississippi, we have patients driving 3 hours just to see us because we're the only academic medical center in the whole state. That's how they can get cancer care. There's just one cancer institute. That's how they'll be lucky enough to get a FEES or an MBS. Some of their educational levels, they're not going to understand the jargon sometimes we throw at them with these handouts that are just printed from Epic, which is our EMR system, and no one's taking the time to explain it to them. I had one physician just kind of throw out, oh, well, there's so many patients complaining they don't get support. Just run an online support group. I was like, do you know these patients don't have Wi-Fi?
Right.
They don't have smartphones. They don't have laptops. They're elderly people. They're not going to jump on Zoom like us and have this support group call. Like, that's just, there's such a breakdown between sometimes I think even what physicians do with patients and how much we can offer them. I just feel like there's so much more to be done.
100%, which is why, I mean, swallowing wellness is really so necessary, you know? The fact that a patient has to drive 3 hours for dysphagia care in any capacity is wild, you know? And then oftentimes, I mean, working in acute care for me, I even hear people say, well, this is the only place I can go, so I needed to come back to the ER just so somebody can take a look at my swallow, because otherwise, where am I going to go? I can't just pop into an outpatient center, you know, without having some prescription or some, you know, way into that center. Where am I going to go? And oftentimes it's the hospitals they just pop into, and the hospitals are slammed, right? So there are all of these logistic things that kind of prevent best dysphagia care. But to your point, you mentioned, you know, kind of treatment being more a very dynamic thing and not static. And to piggyback on that, I remember working in a SNF, and years ago, there are so many patients I'd have who would say, I don't even know what my goals are. I don't even know, what am I actually even working on? And for me, that was just mind-blowing, because what do you mean? How do you know, what do you mean you don't know what you're working on? Like, you know, clearly somebody wrote an entire plan of care, their goals involved, you know, but nobody stopped to take the time to say, hey, these are the things that we're working on. How do you feel about this? Is this even a goal for you? You know, I think it should be a goal based on what I'm seeing, but what do you think? Is this a goal? Is it realistic? Is it something that you actively even want to work on? So we just have to get better about empowering our patients, generally speaking, though.
I've had some instances, and even students when they come in, they're like, you know, because again, they're studying from textbooks where you hear words like gold standard. So they're like asking us, well, is FEES or MBS the gold standard? Which one should I do? And it's still such boxed thinking, which we ourselves have had as clinicians, because that's just the way you're trained. With this protocol-based thinking and not critically thinking and trying to see how you can make the protocol fit the patient. And so, yeah, I've had conversations with patients where if they tell you straight up, maybe they have a neurodegenerative disease, or maybe they're at the end of life, or maybe none of that. Maybe they just decide there's someone like Jim, and I want to continue eating what I eat. And no matter what study you do and what you find, that's not going to change for me. I don't know if I'll be wasting their time and mine and resources and trying to figure out impairments if they're not going to want to participate in therapy just to say I did my job. Maybe there are instances where you will still do that to at least be able to identify what's going on with their patient. But there might be instances where, again, patient autonomy trumps everything. Their desires and their preferences and values and goals should always be a North Star in the way we're treating our patients. There might be cases, and again, I didn't know this as a clinician because I always thought MBS is gold standard for me because that's what I had been exposed in terms of training and access in the hospitals I was in. If I'm realistic, I think fees kind of intimidated me because I had never put a scope down someone's nose. And I was like, I don't even want to deal with that. I don't want to learn about it because I'm just more comfortable with my MBS training. And then in Mississippi, at the hospital I ended up in a voice and swallowing disorders clinic with a laryngologist where we were doing stroboscopies and we had access to fees. Patients had to wait 1 month to get an MBS.
Wow.
Am I going to make them wait 1 month when I have fees right at my disposal to actually see what's going on? Absolutely not. And then, I seeked out the training that I needed and ended up seeking out mentorship, really made sure my skills were at a point where I can start to treat patients and assess patients. And now we the minute they walk into our clinic, we have a multidisciplinary clinic. We'll assess their voice if we have to. We'll do a fees. And most of our patients end up getting an MBS as well because it gives us a different perspective of what we're assessing with their swallowing. We can see the oral phase. We can do an esophageal sweep. We can test compensatory strategies or therapeutic techniques that we may have already started doing in therapy. So yeah, your patients could end up needing nothing, one or the other. They might end up needing both. Again, you just have to really tailor that to the patient's specific goals and deficits, and then kind of plan your assessment and treatment based on their needs versus what a facility tells you to do or what you're comfortable doing.
Exactly. I along the same lines, I was always taught, in grad school, the MBS, that's the gold standard. That is just all that there is to it. And, now both tests are so telling in different ways. You see different things and they're both very necessary in my opinion. And so, for me, pie in the sky, again, what I'd like to see is for every patient for whom it's applicable to have both, to have access to both and really be able to, as the clinician, to compare what we're seeing on both ends, correlate things and really figure out exactly what the complete picture looks like, what it shows in terms of deficits and capabilities. So I'm hopeful. I think we're moving in the direction of being more innovative and more open-minded as an industry, and I hope that we continue to embrace being not so stagnant in terms of doing things the way we've always been doing it, but really just being able to say, you know what, let's try something different, or let's look at it from a different perspective. I think that's going to be really important for us as a field.
Okay, we are back, and you see we did a whole set change just for you guys, and especially for Jim. Jim, how you feeling? Better?
Yeah.
Okay. Are you ready to drink some white chalky stuff?
Sure.
No camera in your nose this time?
Yes.
All in your face, though? Mm-hmm. Okay, so we had a whole conversation, and Jim's drink that he loves is Jack Daniels. Loves him some Maker's Mark, right?
And Coke, yeah.
And Coke, but we don't have any of that. We only have barium. We can call it barium for fun. Would that make it more exciting?
No.
No, not at all. No. I just want to accommodate. Okay, so what we're going to do is we're going to do some tasks. We're just going to get a quick shot, make sure we're looking good. Let's see where he is. That looks good. That looks good. All right, fabulous. So this is annoying. Don't you think, the looping? Why is it doing that?
It is, but
all right, well,
we can try the single shot.
Okay.
Try the single shot.
No, we don't need a single shot. I just don't want it to loop afterward, but that's okay.
Yeah, I can't stop it.
That's okay. Well, some setting happened while we were gone. So we before mentioned EMST. We just want to make sure that we can see the valving of your larynx. Before, you had virtually no valving of that larynx during a swallow. You had some volitionally. You did that bear down Valsalva, right? And you had closure. And then when we did EMST, you had closure, but during a swallow, you didn't have closure. So we just want to make sure, not only for coughing and being able to excrete and that kind of stuff, that you have things working well, but start with the nose clips. And you've done this before. So when we say go, not right now, when we say go, we're just going to get a good shot of you, and then you can put it up to your mouth and blow through it. We just want to see what your larynx is doing. Whenever you're ready, Jim. Good. I meant good for him. I'll tell you when off. Okay, thank you.
I'm watching the time of exposure too.
Yep, absolutely.
I want to keep it under 5 minutes.
We're going to be so far under 5 minutes.
Okay.
Unless Jim, if you do some funny stuff on me. All right, so I need that water. Where's the water? Right here. I just need to put a little bit more here, fill it to the line. So we are using, we're going to start with thin liquid barium. And there we go. You've had this stuff before, okay? Think of this as an apple martini, if that helps.
Shaken must stir, huh?
Shaken. Of course, come on. Always. And so last time we just gave you a cup to do some cup sips to have a naturalistic swallow. So we're just going to give you a little bit of that. And just take a few sips as you feel comfortable. No rush. Okay? We have fluoro. Whenever you're ready. Wow. Oh my gosh. Wow.
Let me go right, yeah.
Did you all?
It cut off automatic.
Okay. Jim? That was amazing.
It felt good. That's the first time I've ever tasted barium.
Wait, I meant your swallow is amazing, but you're saying the barium's amazing?
That's the first time I swallowed barium.
Well, what I want to say is that your swallow is amazing. So I know you don't remember all the images from a couple years ago, but what I'm showing here, first, can we just have you turn around? Do you mind just, I'm sorry that because of the set and the camera, we can't. So now I'm glad it's looping. I know it was annoying before, but I'm glad it's looping now. Look at this. So.
It almost looks normal, huh?
Sorry, what now?
It almost looks normal.
It almost looks normal.
Yeah.
It's definitely functional.
Yeah.
So what we're seeing here, this is the upper esophageal sphincter. So this is a nice clean shot here. So do you see how clear that was? And the time between swallows is so much shorter. You can just get them going.
Right.
You don't have that much secretions, which we saw before. And what we're showing here is that you actually are having much more movement of the neck, much more shortening. Before it was just kind of sitting there. Now, what's that? What do you think? What was that?
A little bit of the aspiration.
Aspiration. Did you feel that at any point when you swallowed?
No.
You didn't feel it. Okay. And you also didn't respond to it that I could tell right away, right? So tell me a little bit more about what you do after you swallow a few things. Do you just naturally clear just in case?
No.
Okay, I'm going to ask you to do that.
Okay.
Would that be too much of a disruption?
No.
And the reason is you were like 90% successful, right? 10%, just a tiny, tiny bit dribbled into your airway. You didn't feel it. That's okay. We'll blame that on the stroke. But importantly, if after you do a series of swallows, you just naturally do it, I think things will be a lot better.
Okay.
Okay. So let's have you turn to the front. Again, we'll get a quick shot. I don't know why our equipment decides that it's going to randomly decide to shut off what we didn't say, like what that was, but that's okay.
Yeah.
Okay.
Evidently it has a limiter.
Yeah, and I asked them actually to change that because it shouldn't even be making the noise, but then we had people come through. It's okay. We had people come through and do things.
Okay, got you.
Cool. We can fix that later.
All right, so shall we get a quick shot right now?
Yeah, let's just get a quick shot, make sure we see where he is.
All right.
Okay, great. All right, so you have just a little bit of residue sitting down there, and it's probably also sort of caught up in secretions. But probably, you can feel it? Flash, please. Okay. Now we're going to go to something a little thicker, okay?
All right.
I know. This is where things get a little bit gunky. We're going to go to nectar, okay? Not too much.
Yeah, I never made it past the barium before.
You mean past the what?
Barium.
Well, it's all barium. It's just different consistencies. So
I never made it to nectar.
you've never made it. You've always made it past something, but puddings really, really get stuck. But I have sprinkles, and I'm hoping I brought sprinkles for you, Jim. Okay. So I'm not going to ask you to take a lot of this. Okay. I'm just going to ask you to take just a small sip or two. Hold on. Let's make sure we're in a good position, please. Okay, great. So whenever you're ready, floral, please.
Interesting.
No more sips, please. Take your time. If you need to swallow, good job.
Nice.
Good job.
So
Do you need a
strong.
cup to spit in? You're good? All right. What happened there?
A little bit of nerves, but I mean, I could feel it coming down the wrong way.
Okay.
That's why you get a little bit of the clear.
Okay. Okay. So this time, your response was very prompt. You aspirated both times. So I'm going to ask you to do the nerve. I know we're messing with your neck, right? But I'm going to ask you to turn around and just look at this. So we're going to start again. This looping suddenly works for me beautifully. Thank you, universe. You see that? Mm-hmm. Okay. And you actually were going to take a sip. I was looking at you. You just stopped to cough. It's so your body was like, no, sir, we will not do that. We have to clear first. Good job.
And it was strong.
Mm-hmm. And then you did it again. But now this time, do you see what happened? It went.
That's made a lot.
Yeah, you did.
That's why you got the second clear cough was a lot stronger.
Right. It was a lot stronger. Good job. And so what do you, I just want to talk about what's happening here. Importantly, your epiglottis, remember that we were telling you before, it's moving so much more than it ever did. But you have to be careful because your swallow response relative to the speed of the food coming down is just not as fast, right? So whenever you aspirated the first time, just give your body a chance to clear something because you can probably guarantee that if you aspirate it, there's probably stuff sitting in those pockets that are your safety, but they're full. Those pockets are full and nothing else. It's overflowing from the pockets into another space. So stop, clear, give yourself a chance, and then go, okay? All right. Any questions?
No.
What do you think?
This is it's very, very helpful
Okay.
to see it.
To see it, right? Leaps and bounds, Jim, though. Leaps and bounds.
But like I said to you, this technology is wonderful. It's so much better than the poster.
Yeah,
Be able to see it and go, okay, this is what I had to clear.
yeah, yeah.
When you're drinking with the thin liquid, you took, sip after sip. Is that typically how fast? Okay, that's what I wondered.
And even nectar, it was a lot faster than I normally would go.
Yeah,
And you're right, because normally I would stop in between if I had to clear,
okay.
and especially eating.
So even
Yeah.
right now, I just want you to take some time and clear, okay? Because I can tell in your voice that there's a little bit extra there, and I don't want you to feel like the production around what's happening should supersede what your body needs right now. So let's just take a breather. I have stuff to mix anyway.
All right.
I do have a question about your sprinkles preference. So while you clear, you can choose your color, okay? And maybe it's just me, but I just feel like sprinkles on barium is the thing. No?
We'll go with the red.
Really? Okay, I thought you were going to go with the orange. I don't know why. Okay.
You thought it was going
All right. I thought you did. So what we're going to do is let you clear a little bit there. I want to test something that moves us up a notch because we want to make sure our time is valuable. We're not going to run away from the things that might cause problems.
Okay.
We know that with thin liquids, you're pretty darn good. Okay. With nectars, even though they're heavier and they fill up your pockets more, they still move fast and they're pretty heavy, so you feel it faster when it hit. You're going to pace yourself in between swallows, right? And when we do this next one, we're going to have you do a little bit, pace yourself. I want to see you try to respond without us telling you anything. Okay? All right.
I'm going to be watching as well so that I don't want to hold the button down the whole time. So after he swallows and clears, I'm going to let go.
No, because if we miss the important information, we're not be able to tell them what happened in between.
Okay.
That's like putting blinders on me and then, or turning the lights off while someone's stumbling through a room. It's like, I wonder if he's going to make it to the other side of the room, the guy with the balance problem, right? Okay, so you tolerate me so well, Alara. Okay. All right, so we're going to get a little heavier. Actually, I'm going to do some thin honey because I feel like the pudding is really going to gunk things up. Any questions, Savannah?
Oh, this is it's a huge improvement from the previous.
Okay, so we'll do this for now. We're just going to take a little bit on a spoon and swallow it. And it's sort of like not Greek yogurt, a thinner yogurt is what it's probably close to. So just take a spoonful and you can swallow when you're ready. There's not enough here for you to have too much. Remember, this is heavier, so what do you think might happen?
Don't know.
You don't know? Me either. Let's see.
Because I have eaten yogurt before.
You have?
Mhm.
How does it feel?
Fine.
The only thing is this is not cold, and I think cold works well for you. So I do have another cold option here that I think you will like.
I do the temperature, the cold, those work.
I can tell. Okay. So we're going to do this room temperature one. Wait, before you go, how do you feel? Do you feel clear? Do you need more time?
Do you
A little bit.
Need more time?
Maybe like 2 minutes.
2 minutes? Take as much time as you need.
I'll hold on to this.
Okay, take as much time as you need because I'm going to work on something else. And what I did, so we actually did a study where we tested frozen consistencies. And we tested frozen barium, I'm going to put this in here, and we tested frozen pudding. And the pudding and barium, the pudding and frozen liquid barium, like ice, act differently than when they're room temperature. Because you like cold better, we definitely want to test, but it's going to be thicker. So thicker things get a little stuck with you, but at the same time you feel them better because they're cold, right? Yeah. And I think it's more enjoyable. So I'm going to find a cup to put that in. Oh, here we go. While you take some space. So people are wondering, all I really did was freeze the pudding before, and so it's been sitting in this cooler. Do you want to do cold before you do that one?
It's up to you.
It's up to you, actually.
No, it doesn't matter, man.
If it doesn't matter, then which do you choose?
We'll do the cold.
Cold? With red sprinkles?
Yes, please.
Just a couple of red sprinkles? I know, it's so fun. Okay. I think I'm probably the most excited person in these studies, more than anybody else. Just a little bit of red sprinkles. Just for fun.
Because why not?
A little texture. It's not much, but it makes it fancy. Okay. Now, before you're ready, let's make sure we have a good shot of you. How does he look? Looks good from our end. Okay, so you're just going to take one small, not a big teaspoon, a small one. This might take a little while. Okay?
Like this?
Yeah, that's good. Floral.
Thanks.
Oh. You're doing well. Take it off. How'd that feel?
Fine, except for the sprinkles.
Oh, you don't like the sprinkles. You don't like the sprinkles.
Because, consistency is either going to chew it or swallow.
So it kind of almost feel like.
And that's exactly what the test was. So we had it with chocolate chips and
See,
the other
one of
one.
the sprinkles like in the back of my throat.
It might be back there. That's good. So you can feel the texture. So you need texture and temperature. So you were able to keep track of the bullets better. You're able to keep track of the food better because it's there. Although you don't love the feel of it. Is that fair?
Don't like the feel of which.
So when you said you didn't like the extra texture, it didn't go down the wrong way, if that's what you're wondering.
You still have like a lot of eyes, so you really want to do well. So I wasn't sure to chew it or to swallow it. So if you try to swallow, that's when the sprinkles are caught.
Well, this looked really good. Do you want to turn around and see? Last time, it just took forever to even get there. Do you remember?
Yeah.
So it's gonna start again. Now, see, this is the space right here where you're having some difficulty. This is your upper esophageal sphincter, but it does open so much more. Here we go. We'll start again. Look at that. All right, so here we go. Look at that. That in the beginning, it would all just be working its way down here very slowly. You managed to move it down much more quickly and get maybe about 50% through.
So you can see the one sprinkle, I think.
So I don't think you can see the sprinkles because they are not contrast. So they need to be barium for us to see sprinkles. Yeah. Maybe you can feel the sprinkle. I'm so glad you can still feel that though, because that's telling me something about sensation. The fact that you can actually tell that that's still there and the cold, right? How does it feel now?
Okay.
Yeah? You're burping a little bit. Good. That's good.
What made you feel like the almost like the halfway throat clear? What were you feeling that made you do that?
I think it was like a little bit of confusion. Because I knew you wanted me to swallow, but I wanted to chew.
Oh, okay.
Because if I was eating younger with fruit, I'd be chewing it out.
Okay. So you can do whatever you want.
Okay.
Okay? I want you to manage the food however you feel best. Okay? You can do whatever you want. Okay?
All right.
All right. So you said you do fruit sometimes?
Pardon me?
You do fruit sometimes?
We eat younger with fruit.
Okay, so what we want to do now is we want to test the other thing that you said was really important for you. We got through 3 of them. We got through the thin liquids. So you were talking about being at a bar and sometimes in between you feel something goes the wrong way. What do you do? So we kind of have some answer there. We got with the nectar, we understand that you can pace yourself, right? Pace yourself better. We got through something heavier with texture and temperature, and you're doing pretty well with that. You're keeping track of the bolus, right? And the last thing is something you need to chew. And the reason I want to make sure we test that is because you talked about your dentition changing because of the reflux. And I just want to make sure that the chewing is working well enough so nothing's getting majorly stuck. Okay?
Okay.
Do you mind if we do that one more?
All right.
Okay. Now remember always, you're doing what you want to do. Okay? It's not about what we want, it's about what you want. Okay? There's no failing.
All right.
And I know in the past that was a concern, but there's no failing. Okay? There's only winning. All right. And you like Lorna Doones, right?
Yeah, we didn't get to the Lorna.
That's right. I think we have one out. Do we? I bought these fancy Biscoffs. And you like Lorna Doones. Go figure. All right. So I'm going to take a piece that is very small. And how about I put it in a cup with the... right here. So I'm going to put it in some cold pudding so that we don't have with a spoon with no sprinkles. Okay? But you can see
Because I need to chew it.
Yes, well, you're going to have to chew this for sure. But we need the contrast there so we can see it.
Okay.
And you do have to chew this. So it's not like the sprinkles, you could technically just swallow them, but you were not sure. So when you're ready, not the second, you alert us and you just take a bite, okay? Just give us the thumbs up when you're ready to go. No rush.
Ready?
Okay. Laura?
Okay.
Can we get on? How's that feeling?
It's fun. I think I chewed like a little bit faster than I normally chew.
Okay.
Might have been nerves.
Okay.
But I could feel like a little bit of clot in the back of the throat. Maybe clear. Mm-hmm. But I think it's important to learn to clear.
You're a master at getting the food down, making a decision, and bringing it back up before it goes into your airway. Am I right? Am I right?
It's like the body was like saying, not ready, go back up.
Yeah, the sensation is what's like blowing my mind.
Yeah,
the
your
sensation.
body has figured out its own way to functionally manage food.
And see, I think like a lot of people are like that.
If we let them try.
Yeah.
Because we know our body's better than anybody else.
Yeah.
You are the expert on dysphagia, not me. I don't know why I'm getting any excitement around me, because you're the one who understands this. You actually illuminated all of these processes for me over the years. So I want you to turn around, if you don't mind, one more time and see. Again, this would have been in front of you or in a real clinical situation, but for the sake of all the production, here we are. So we're not at the top of the swallow, but I'll tell you when we are. And now you've seen all these things before, but again, this is that pocket where the green stuff would have been if you were looking at the applesauce before. So this is the opening that you thought was bigger. This is the space that you don't want food to go in. This is the space you want it to go in. And right here is where the Botox goes that doesn't open long enough, okay? So what's happening is, and we'll actually get back to the top of the swallow, but we'll see. You're actually going to bring that back up. See? Boom, right back. You're like, nope, not now, a little later. And you see what happens when it doesn't open, it sits in that pocket. The pocket is doing its job really well. And your sensation in this area is really, really improved quite a bit. So you see how it opened for a second, but not enough to get this through. So what you're doing is you're actually saying, I don't trust this pocket, so the most of the pocket's like too much going on here, and you just put it in a safe space for a while.
So that's where the Botox comes in. They dilate it. They have a new balloon.
Yeah.
That's only until the Botox takes effect. Because the Botox can take up to 3 or 4 days to take effect. I think it relaxes that. So that's why you're 9 months in since my last treatment of Botox.
Okay, interesting to see right after.
Yep, absolutely. So essentially, your body's kind of handling it for you. So for whatever reason, our profession and many professions don't let the body have a chance to restore itself, right?
And, well, that's always been my argument. When you put somebody in PO, you don't swallow. So how are you going to learn to swallow and control stuff?
Yeah.
Because I remember, because I used to sneak ice when I was at the hospital.
Okay. So you used to sneak ice, which is good for you. We can see the ice is good for you.
Even when I got home, because I would try like little ice or water. You know, I might spit it out, but
Yeah.
you know, I think that's let us. So if that was more controlled, so if you could watch it, you knew what was happening.
Right.
Because the body can understand what it's supposed to do.
Right. So you have, before your stroke, in your brain, all of these categories of things you can do. Think of them of all these buttons of thin liquid with a straw, teaspoon of pudding, all of these things you develop during weaning, really when you're very young, because at about age 5, you have an adult model of a swallow. There's generally not much a kid can't swallow. They're not like, oh, what's a cookie? I don't know what to do with that. They know how to do all the things. Then your stroke comes in and says, we're going to snatch a few of these. And it's our job to go, oh, it snatched that program and that program. You can't do straws. You can't do this. And we need to give you back those experiences so your body can figure out how to flick those lights back on. It's just sort of like a panel in a house. You walk in, some rooms are dark, and it's our electrician's job to go and flick them back on. But if we don't let your body get the time to experience that difficult thing, it won't know how to flick that program back on.
Correct.
And you flick the program back on in a big way because you weren't told to stop eating, it's dangerous. You were given the opportunity to let your body try.
And being able, when I was down at University of Florida with you first time, you were able to see, on the big screen. Because I can remember the very first, because we can go back, because it'd be really interesting, compare.
But you had to try
And
so
really,
many
the
things.
short period of time that I saw you down there, I mean, over, what was it, maybe 6 months?
It was over a year. The visits were spread across a little over a year from visit 1 to somewhere around visit 4.
But if you took visit 1, compared to visit 4, and compared to this, it's huge.
Huge. I feel like if you came here next year, this time we'd be like, now, Jim, do you even need to be here?
The,
Our swallows look the same, Jim.
but, so, I mean, that's what the people really have to look at, I think.
To give you the chance to grow and practice it and get better. Great.
Yeah, and not be afraid. Not be afraid to give you that freedom.
Yeah.
It'd be, and that's where you can play a part, because the person should be able to clear. But because I remember, the very first time came down,
There were so many things that had to be trialed before, like even getting anything successful.
Yeah. So how do you feel right now in our last few minutes or so about your whole experience and the progress? Do you feel like this is confirming what you felt in your body over the time?
yes.
Good.
And like I said, being able to see it, and even the fees, because when you took the time to explain what I was looking at, that was really very, very helpful.
Good job.
Okay. Do you feel a little bit better about that procedure now
Yes.
than you did? Okay, good.
How's your neck?
It's okay.
Yeah. I know that I just want everybody to, wherever you are, round of applause for Jim for even being
Yeah.
willing to do this. It's tough just to have any health problem and just be with the 2 clinicians in a room. It's tough to be in your house with your health problem, just be thinking about it. It's super tough to share this with the world, but I want you to know, in addition to leaps and bounds in terms of how your swallow's grown, what you've done for our profession by being willing to share your story is going to just resonate for years and years and hopefully decades, because we need to hear your true opinion. In between takes, we're like, don't you love how frank he is? And he's like, the poster sucks. I don't like this. That's what we need to hear.
Yeah.
But most patients feel like, well, they're the experts.
Yeah.
They tell me.
Yeah.
No, we want you
Yeah.
to tell us.
Yep. Exactly.
But that was your advice.
Yeah. Well, don't take it from me all the time. I'm too mouthy sometimes. So. But it's helping you, right?
I wish I'd spoke up more when I was in the hospital.
Yeah.
It's kind of hard. You just had a stroke. It shouldn't be on you to have to speak up to defend yourself. But I hear you saying if you had the capacity in retrospect, you would have said, no, I
But
wanted
if you're
you.
doing the same thing for 3 months, you would expect, it's the definition of insanity. You keep trying the same thing over and over, no results.
Yeah. So you're talking about the first 3 months that you had speech pathology therapy and it was always the same thing. You wish you had said, hey, mix it up, people.
Yes.
Okay. Okay. I hear that. Mix it up, people. That's what he's saying. Any other last thoughts? Savannah? Jim? All right. Well, we can take it to Rinky and Leticia. Thank you, everybody, for joining us. I had a fabulous time here. I hope you guys had a fabulous time watching this. We know that we are in a space in our field where we are really just trying to figure out how to get better. We're moving away from disability reduction to restoration of function. We're not just giving people crutches and saying don't eat or always avoid these foods. We're saying let's try to get your body to a place where it knows how to practice to get better at something. And so he is a great example, especially if you saw what he looked like with the brainstem stroke. A year after the brainstem stroke, everyone say, oh, there's no hope. I hope that this last 2 hours was just manifestation of hope. All right. Those are my last words. Thanks, everybody. Take it away, Rinky and Leticia.
Boy, that was eye-opening. Wow.
Genuinely, like I can kind of see it with you too. Like I was teary-eyed and I was emotional and I can feel it in my bones. Just what a powerful learning experience this has been. And I hope everybody watching kind of feels that too. And like Inessa said, we're hoping to do so much more of this. I think it's going to impact so many students, so many clinicians, and it's not easy being Jim. So, I mean, I really thank him to be
Definitely.
willing to do this because that's what's going to improve patient care. Because
Indeed.
maybe the 60 people watching will go back and resonate with something that happened today more than just beyond watching an MBS or watching a FEES. Those are skills you can pick up. But these real patient interactions and hearing from the patient, that's what makes us compassionate, confident, competent clinicians. So I hope that's what everyone takes away from today.
Yeah, I can't say enough about just how Jim has been so instrumental, pun intended, in the way that we look at the patient experience. Because, you know, when he said, "Thank you for giving me the time," or I think it was Ianessa who might have said, "No, do you need more time?" And even something as simple as that, do you need more time? Do you need more time for your body to do what it needs to do? I think oftentimes when we go through these evaluations, like, let's just get through it. Let's go from thin to nectar to moderately thick, if that's what's necessary, and go through the transition of things. But do you need more time? Are you okay to proceed? You know, something as simple as that goes a really long way.
You know, we're a big believer, I think, at STEP and at Swallowing Wellness of innovation. We are always looking to kind of push that envelope and challenge the status quo and break the glass ceiling and all of that. So again, thank you everyone for being part of our first help session. It really is Dr. Ianessa Humbert's creative genius and scientific training and clinical expertise that drives all of this. So rightly so, we wanted to call it the Humbert Experiential Learning Program. That's kind of her way of making her mark in the field and leaving a legacy, like she said, hopefully for decades of students and clinicians and patients to come.